Slightly older slide, but this is the last updated slide. Around 350 pediatric heart transplant was take place in the entire world. As we go on from infancy onwards, the diagnosis for which they would require this would keep on changing. So in an infant, you would have congenital heart disease, which is not amenable for a surgical therapy, or the patient has had some form of a therapy which is not working, and those are the patients who will be eligible for a pediatric heart transplant. When you go to 1 to 10 year age, this thing changes. So you're now seeing again cardiomyopathy as one of the most common causes for offering transplant to them. So it changes. Congenital heart disease remains a significant second, but now cardiomyopathy has overtaken that when you go from less than 1 year to 1 to 10 year of age. When you progress beyond that, around 11 to 17 years, now it changes completely again, and it is again 63% of them are actually cardiomyopathy patients. So this is very, and 27% are still congenital heart diseases. So in pediatric transplant, this is what this entire etiology changes from infancy. The thing skews towards cardiomyopathy as we progress from less than 1 year, 1 to 10 year, and greater than 17 years. Now to talk about India, in India we have made a journey as there was a big lull. So you all know that the first transplant was done in All India Institute with a lot of fanfare on August 3rd, 1994, when Dr. Venugopal did the first heart transplant. What many of you would not know, that heart transplant was done in 1968 in KEM, Mumbai by Dr. P.K. Sen on a deceased circulatory death donor after a cardiac arrest, because there was no legal thing not to do it. And he had done a lot of canine experiments, and he was the 4th person in the world to do it. Only 3 other persons had done few months before. So, but obviously that was a deceased donor circulation where the patient had arrested in the next room and they harvested the organ. Heart kept on beating for around 16 minutes and then the patient succumbed. Was a young patient with a dilated cardiomyopathy. So we started this journey really early in 1968 thanks to his effort, and this was not just one-off thing that one day he just did a transplant. This was based on approximately more than 100 canine experiments in the animal lab of KEM. After that, there was the legal sanction came only in 1994 when the first heart transplant was done in All India Institute, followed by Dr. Cherian in Chennai. And after that, there was a big lull. So till around 2004, the number of transplants that would happen in India were less than 30 in a year. From there, if you see, it had progressively increased, and now still compared to the population, it is still minuscule, but approximately between 150 to 200 transplants, heart transplants we are talking about, happens in India every year, and that has been the trend for some years now. Some years it has crossed 200, but that is an oddity rather than the rule. So there are many centers which have come up, and based on that, you can see that it is sort of last is 2021. There were 151 heart and 133 lungs, and some of them are heart lungs as well, but that is in singular number. So we have now been able to establish, we have an Indian Society of Heart Lung Transplant, and after a lot of coordination with participating members, institution, and because it is a smaller cohort of surgical professionals and other allied specialties who have come together, we actually have a registry. And people do sort of sincerely update their data. So this data is as close to real as can be in an Indian scenario. And till date, this was published sort of last week. So we have a data of 1,328 heart transplants which have been done since the beginning in India, 475 lung transplants, and around 128 LVAD have been implanted. 61 of those transplants were done for the COVID lung disease. And when we talk about West Bengal, these are the centers which are licensed to actually carry out heart transplant. And most of them have done, barring one center in this list who is still not. Everybody else has embarked on this journey, although it is just a beginning for the entire city. So this started in 2018 in the city of Kolkata when an out-of-city harvest was done by Fortis Hospitals, and that was the first heart transplant in Kolkata in 2018. After that, 7 centers have started this journey. One center, Dipanjan is here so he can enlighten us more. One center has embarked on the journey of lung transplant. 2 centers are actually licensed to carry out lung transplant currently in the city of Kolkata. There have been no other transplant outside the city in this state, and we hope that that changes soon. So in this period of 2018 to 23, 28 heart transplants, according to the whoever have, it might be differing by 1 or 2 numbers because of if somebody has not updated. 28 heart transplants has taken place. If we classify them into pediatric and adult, we are the only centers who did, out of our 6 that we have done, 3 were patients who were less than 18 years of age. So although 2 of them were dilated cardiomyopathy, again the age group in which pediatric heart transplants happens for this particular etiology, and 1 was an end-stage Epstein with severe biventricular dysfunction who was not suitable for any other surgical correction, and we took them up from transplants. 2 lung transplants have been done in the city of Kolkata. So if you see the percentage increase from 0 to 28 in a span of 5 years, it is not bad at all. So this is how the paper distributed entire India, and you see darkest of the green is the maximum number, so that is Tamil Nadu. This area is still in lighter shade of green, but we are at least not in red, so we are still in yellow. So which is an encouraging sign. We hope that we make from this journey to a lighter shade of green and darker shade of green and someday. So there are isolated 2 spots of Delhi and Chandigarh in the northern India, otherwise rest of it is completely red. So are our neighbors. So which makes us uniquely positioned to offer this therapy to the neighboring states, because this is not something which should be carried out everywhere. There is no point of having numerous small programs. I think few large programs which are capable and can actually support the population's need is probably the way to go, like it happens in the West. So as I said, this is the breakup of those 1,328 transplants which can happen in India, and average rule of thumb is 10% of the transplants in any place are pediatric. So in India, this is based on personal communication, it is not even 10%. So it is less than 10% which is actually pediatric heart transplant. So in this part of the world, it's still sort of a newspaper item when you do a transplant. So these were a few of those reports which got published after we did some pediatric heart transplants here in this city. And our youngest was a 13-year-old who received because of end-stage Epstein's anomaly. So, as I said, you saw the first slides, the indications are fairly common. So it has to be a cardiac pathology who is on a need for an intravenous inotropic or a mechanical circulatory support. There must be some congenital anomaly which is not amenable to conventional surgical repair or has been palliated with something and it's not working. And they would be obviously on significant amount of medical support, progressive ventricular dysfunction, malignant arrhythmias, or a significant pulmonary hypertension, which would make him ineligible for a heart transplant very soon. That is also an indication. And other Anne is struggling with heart failure with a unacceptable poor quality of life. So these are the indications that you will choose a pediatric patient for a heart transplant. If we concentrate on the congenital heart anomaly subset, then these are the commonest pathologies that would become eligible for a heart transplant. Obviously, single ventricle ones are the commonest in this subset. And again, this is AHA heart failure staging, which is fairly common in adults as well, and it classifies not according to your NYHA and stuff. Obviously, the acute staging that we use, we would use a different score, but heart failure classification would actually classify them into A, B, C, D, where A is just he's at a risk of developing heart failure. B is when there is abnormal cardiac function or structure along with it. And when you combine the both, they go on to classes C and D, which would actually be eligible for a heart transplant. Now, why do these children actually need something as intense a therapy like transplant? Because 90% of congenital heart disease that we treat these days, a significant proportion of them are palliative in nature, and 90% and more than 90% of them will actually survive into adulthood. So they are living longer, and with that comes a new form of disease burden, So there are residual anatomic issues, there are arrhythmias, there are late ventricular dysfunction, and they progressively go into the category of so-called heart failure patient, and untreated, they have a very poor prognosis. So in the adult, all those patients who have been diagnosed as a congenital heart disease in adulthood or has been treated by another surgery in their childhood, 3.3% of those patients will actually become eligible for a heart transplant based on their heart failure criteria. And world over, in the last 10 years, the number of pediatric heart transplant has increased by 40% of their initial number. So it is still less than 10% of the entire exercise of transplant, but it is showing more and more this therapy is being available for children. But it is also more difficult than an adult transplant. So obviously there are some anatomical issues that we need to scan much better and plan ourselves when we are doing a congenital heart transplant, because most of them would have had either a Fontan failure, so you would have 2 surgeries before. We need to know the status of their caval veins for our anastomotic purposes. Some of them will have persistent left superior vena cava, which would need to be addressed during a transplant, and your donor heart won't have that. You will have significant pulmonary artery reconstruction done in your previous operations with some residual issues which would need to be addressed to perfection, otherwise the new right heart will start struggling. You will have some of these single ventricle with aortic arch anomalies, or even if there is a Norwood survivor who actually has failed a Fontan, you would have some amount of aortic arch procedures done on them. So the imaging has to be of a different magnitude when we are dealing with a pediatric heart transplant recipient. Obviously, it is all sort of arterial Dopplers, battery of blood tests, and evaluation by a psychologist, psychiatrist, just to evaluate the psychosocial milieu in which the patient lives is also very important as a part of pediatric evaluation. Why it is more challenging? It is not only anatomy, it is also physiologically. Almost 90% of pediatric transplants will be redos. So you need to have the normal challenges of sternal re-entry. You need to have a strategy for your systemic venous reconstruction, because these patients are all post-operative patients. Venous gradients are very poorly tolerated, so our anastomosis has to have completely laminar flow for them, for the new heart to work well. As I said, the right heart will struggle if there are residual gradients even distally. So we would see the main pulmonary artery as our main anastomosis. Here it does not matter. Here it matters if your branches flow well or not. In addition to that, the systemic outflow has to be perfect. So there should be the new heart will only have ascending aorta in it. Your aortic arch will still be native to the patient. So those all things have to be taken into account. There are some very good papers on how to reconstruct systemic venous, but these are all sort of hardcore surgical things. So I've just put that. That is an important point. As surgeons, it takes away a significant amount of our efforts to actually sort them out. In addition to anatomy, I think the main thing is physiological challenges as well. Some of them will have bleeding, impaired coagulation because of cyanosis. They'll have the estimation of PVR in certain anatomies is difficult. Pediatric heart transplant recipients have a higher need for right heart support, including nitric oxide in the postoperative period. Incidence of profound vasoplegia necessitating higher sort of vasopressors is higher in chronic cyanotic patients who undergo a transplant. And they also are more prone for pre-op renal as well as hepatic impairment, which can have a prognostic implication on your postoperative. In addition to this, because they have had a previous surgery, they're all exposed to blood products. So they're all allosensitized. So that is another thing that we would actually, and some of them will have received a homograft, which is also a very strong sensitizing agent. So they will very commonly, if we do a virtual cross match, you will find them positive. So obviously, if a virtual cross match can be positive and your CDC cross match, if it is negative, then you will still proceed. But you should have a clear-cut strategy of how to tackle immunogenicity problem in a pediatric heart transplant, with a strategy that you should have a protocol for plasmapheresis, escalating to immunoglobulin, rituximab if needed. So they might not work with conventional immunosuppression. In addition to that, interpretation of anti-HLA antibody is difficult, and also the clinical significance of it. So these are the problems of allosensitization that we fail. As I said, other organs have already are not in their prime, so kidney, liver, and other organs can give a challenging postoperative period to the patient. And in a Fontan failure, some of the units would actually do a pre-op liver biopsy almost always, or do a fibroscan to know the status of the liver before you offer a failing Fontan, a heart transplant. You need to know whether the liver is all right or not. So that is just one aspect of a failing Fontan, because that is the largest subset of congenital heart disease patients who would receive a transplant. We need to evaluate their preoperative congestive heart failure status. whether there is any AVVR which is leading to other issues in the lungs, arrhythmias, low cardiac output, ascites, cyanosis, whether the hepatic insufficiency is surmountable or necessitates heart and a liver simultaneous transplants. So there has been one combined heart and liver in India so far. Only one institution has done so far. In addition to that, common problems of a failing fontan like protein losing enteropathy, plastic bronchitis, so their lungs might not be optimum at all, hyperproteinemia, in addition to the surgical challenges that we were talking about. So all this together makes them a very challenging subset. So let us now see, after sort of we have enlisted somebody and done a transplant, how well they do. So there is a peculiar thing about congenital heart transplant which is different from adults, is their immediate postoperative morbidity mortality is higher compared to an adult population. However, if we go to 5 and 10 year, if you see these forest charts, you will see that they start performing better than our adult recipients. So yes, the initial period is more challenging. However, if they survive beyond 5 years, they tend to do better than your adult recipients. And that is what is depicted here in this particular graph. So it is an encouraging scenario. This therapy should not be denied to anybody for this being a challenging surgical exercise. What are our peculiar challenges that we face? Congenital heart disease, transplant, any capital intensive surgical exercise, it is the funding. So it is a lot of funding involved in it, not only for carrying out the operation, but also for immunosuppression in the longer run. Logistics of organ transport. So we are still at infancy. We mostly do road transports, but we also have to realize that if we are relying only on road transport, then our number of potential donors is also very less. So unless we have a capacity to transport an organ which is within 4 hours of an aerial distance from our city, we are losing out on many organs. Post-transplant surveillance in children is often challenging because of their small size. Repeated biopsies are not easy. So we need to again develop a program of non-invasive surveillance program by doing cell-free DNA, by doing liquid biopsies. So there are non-invasive ways to know rejection, as sensitive as an endomyocardial biopsy, which is done to basically establish whether the heart is getting rejected or not. So funding and pediatric organ donations are probably the main challenges that any pediatric transplant program will face. There has been no pediatric organ donation in the last many years in this city, and that is again a challenge. So many of you are also working in pediatric ICUs, and ICUs are the places from where an organ donation exercise starts. So let this be a sensitization for that in those unfortunate situations where we have lost a patient in a pediatric ICU for a non-cardiac pathology and the other organs are good, it is never too late to begin that conversation with that unfortunate set of parents. Maybe it will save another life. Late referrals are very common because we would have sort of multiple patients coming in their adolescence with their ventricle. It is a dilated cardiomyopathy but has come to a state when the first time we see they have arrested in our emergency. So that is like a really late stage to see them. Whether we can salvage them or not is very challenging. In addition, any program, here in Kolkata we face a peculiar challenge. Sometimes we are not able to utilize the organ because there is no appropriate recipient in any of the listed centers. It happens in all programs. So you will have an organ, but you will not find a recipient. So we keep on talking about lack of organ donation, but finding a suitable recipient means that every center should have a very robust, already worked up recipient list. And it is not, everybody is still developing their program. So there are times when there is an organ and there are no suitable recipients in the entire city and in the neighborhood in West Bengal. So some organs get wasted because of that. And there is lack of organized heart failure clinics in surgical as well as pediatric cardiology and adult cardiology setups, which again makes this exercise more challenging. So to conclude, I think heart transplant, we all know, is the final milestone in many congenital heart disease as well as pediatric patients. Early mortality and morbidity remain very high, but I think the long-term survival is better. So any patients who actually qualify for this should be offered this therapy. There are unique surgical and physiological challenges. So just because we have started doing an adult program, we can't sort of simultaneously jump into building a pediatric heart transplant or a assist device program. The team has to specifically train for it before embarking on that journey, because it is not a natural transition. Proper patient selection, judicious and more aggressive use of supporting them by mechanical circulatory support, Shubhadeep will speak after me on this, and early referrals may further lead to reducing this early mortality morbidity period. If we see them early, we pick them early, and we do them earlier, maybe their early phase of mortality might even become better. So as I said, I was told to talk about pediatric heart transplant experience in Eastern India. So it is too less a number to actually talk about based on personal experience. So I thought I'll just conglomerate the entire Indian data and present you this. Thank you.
I would like to call upon stage Dr. Deepanjan Chatterjee, ECMO physician and lead in cardiac intensive care at Medica Super Specialty Hospital, to hand over the memento to Dr. Das.